All right, thanks, Eran. Boy, it's kind of a very selective but special audience. It's too bad everybody else is missing out because they're going to hear about what the future is. I'm often asked about what's next. I kind of grew up during the laparoscopic revolution. I kind of spearheaded a lot of innovations along my career pathway. And so people come up to me because I'm old and say, well, what's going to be the next laparoscopic surgery? What's going to be the next minimally invasive thing? So I'd actually talked to Dan Jones, introduced him to Eran, and suggested that this would be a good session for SAGES, which tends to be, as all surgical societies, kind of a pioneering one that concentrates and introduces new things. Because I think, and several in the audience would agree with me, that maybe the next minimally invasive surgical revolution is going to be percutaneous image-guided interventions. Conflict of interest, none of which really deal with this. So, as many of you know, I've spent decades championing surgeons doing flexible endoscopy. It's kind of what my practice is. And I think thanks to organizations like SAGES, we've made a great headway with that, not only in the United States, but around the world. And now it's kind of accepted that surgeons can and should do things like POEM and ESD and their own stenting and their own endoscopy, and that's been good. And my big argument has always been that if surgeons didn't do it, they'd lose their practice. That things are migrating away from surgery and towards endoscopy because it's less invasive, even than laparoscopy. And for that reason, numerous, and I always show this list just to stir up surgeons, numerous procedures that we used to do surgically or laparoscopically have disappeared off the books. And now we do them with an endoscope. And if you don't do endoscopy, somebody else, another specialty that will remain unnamed, will do them for you. And it's a lost opportunity. So the world of open surgery has vanishingly shrunk. The world of laparoscopic surgery is shrinking. It's all migrating downhill, and things are getting endoscopy. So all of you have heard me talk about that over the years, and that's nothing new. What I tell the gastroenterologist, since I'm half gastroenterologist, surgeons tend to think I'm a gastroenterologists tend to think I'm a surgeon, is that endoscopists need to watch out too, because much of what we do endoscopically is migrating towards image-guided interventions. So things like placement of stents and feeding tubes, dealing with strictures, palliation, ablations, a lot of those things that were endoscopic, used to a long time ago be surgical, are now migrating to percutaneous approaches, image-guided approaches. So nobody's safe. If you don't follow these trends, pick a disease and follow the technology trends rather than picking a technology and trying to find diseases to use it on. You get in trouble doing that. I work at a place in France. It's called the IHU-Strasbourg. It's an Institute of Image-Guided Surgery. And I wanted to just talk a little bit about that because it's kind of focused on this whole concept of disease-focused treatments in the least invasive fashion and changing the paradigm of kind of siloed training and silo practicing. So kind of at the origin of this, it's a fairly new project, started in 2012. Our building opened in 2016. We said, what do these disciplines have in common? Minimally invasive laparoscopic surgery, interventional endoscopy, interventional radiology. And really they have these things in common. First, they're minimally invasive. They have a focus on providing patient care in a less invasive fashion because it's normal. That's what patients want. That's what we would want for ourselves, for our families, and that's what patients want. Patients will leave your practice if you don't offer them that. In the early days of lap chole, people would stand up out of the waiting room where they were waiting to see a consultation for their open cholecystectomy and walk out and walk down the street and find somebody that did laparoscopic. Same thing happens with achalasia treatment. You offer laparoscopic Heller myotomy, somebody down the street offers a endoscopic myotomy, a POEM procedure, patients stand up in the waiting room and they walk out. So all of these, it's a basic fundamental thing that patients want less invasive therapies. Comparison number 2. So here's 3 different practitioners. Notice they're all looking at video screens. They all have a computer of some sort and a video of some sort in between the patient and themselves. And so that's another hallmark. All 3 of these, at first glance, you can't tell which one's the interventional radiologist, which one's a gastroenterologist, which one's a surgeon, because we all kind of use this very familiar tool, and it's an empowering tool, it's a digital tool, and it's infinitely flexible, and it's changing very rapidly. Number 3, our tools are very similar. Some are more flexible than others, but the tools that interventional radiologists use are similar to tools that flexible endoscopists use, and they're all trickle down from laparoscopic tools, which are probably the most evolved as far as the end effectors go. And this is another similarity and another evolutionary thing. So the institute I work at in Strasbourg had this proposal of kind of combining all these very similar specialties into one hybrid paradigm that would kind of overlap and then leverage off that augmented digital element of it to kind of make it learnable. Obviously, you can't learn like Professor Shlomovitz did and do 3 full residency fellowship training paradigms, but we think and we propose that with digital assistance, we can really achieve this kind of welding and melding of these different disciplines. So what's needed to create this new field of percutaneous surgery? Hopefully you'll agree that's kind of an interesting paradigm. A, it needs a home. Standard operating rooms aren't really amenable. Standard interventional radiology suites aren't perfect. Endoscopy suites aren't really the best place for it, so we need kind of a hybrid paradigm to practice these things. And that's kind of, Emilcar Ozagas here from Siemens, that's kind of this hybrid OR concept of having operating rooms augmented with capabilities of doing flexible things, capabilities of doing image-guided things, so bringing these large imaging tools in and kind of breaking down kind of the isolated IR suite down in the basement of the hospital, far away from where patients are consulted, seen, operated on, etc. You need a new type of practitioner. So if you really want a hybrid reality, it's very hard to get 3 guys around the table, your gastroenterologist, your surgeon, and your interventional radiologist, and have them working happy together. It certainly is impossible to get them all 3 paid for doing the one procedure. So to some extent, we need to develop different curriculums, different training pathways to develop a different kind of practitioner. And we need new tools. This is really an opportunity rather than a need almost to do these things. It's a great opportunity to look at these other disciplines and take the best tools from each of them and kind of make it happen. So these are kind of core mandates of the IHU-Strasbourg. We kind of cover education, kind of reformatting in France, surgical education, developing new tools, and changing how clinical care is done, partly by designing these things. So we invest a lot in research. A lot of that's around enabling science to make this a reality. It looks at hybrid device development, things like augmented imaging, virtual reality, et cetera, robotics, and of course education as well, designing new curriculums for these new training pathways. Oops, I'm going the wrong direction. So enhanced imaging, we think, is kind of a key to the future. It's partly these big MRI things, but it's partly kind of leveraging more usable technologies like ultrasound and kind of improving them, maybe giving interventional radiologists the capability of seeing things on a video screen, so video input instead of just looking at X-ray images, etc. So that's certainly things. Kind of our friends at Siemens kind of work with us and collaborate to kind of up the ante for standard imaging and give us super high resolution images to that even a surgeon can intuitively see. When you have an image like this, you don't really need a radiologist to interpret it for a surgeon. An image like this is intuitively graspable by an interventionalist, a gastroenterologist, or a surgeon. Augmented reality, kind of computer augmentation of how we see, also is kind of a democratizing thing for interventional radiology. So we invest a lot in research on this kind of thing. So taking standard images and essentially working those images digitally to make them more usable for the practitioner. So that initial image I showed you, that X-ray image, is interesting for a diagnostic thing, but for a surgeon to actually practice and intervene on something, it's not so interesting. But once you do something like this and recreate it in a virtual format, a patient-specific virtual format, then it's usable. Then you can turn it around. It's almost like a model. It's almost like having your hands on the patient themselves. You can practice the surgery. You can see what would happen if you do an ablation here, how much tissue would kill, et cetera, et cetera. New ways of imaging. So making screens and videos, we all use them. They're all the same. They haven't changed. They got a little bit flatter, but they haven't changed a great deal. But to make these more democratic, more usable in our everyday environment. So maybe for surgeons that are in sterile environments, not to have to touch the image, to have it on the operative field or in the endoscopy suite, to be able to manipulate it, turn it around. All of this is coming to fruition. So we're bringing these out right away because we think it kind of pushes this aim of a hybrid future. And then finally, I kind of made reference to kind of difficulty of teaching this kind of thing. And we think that you won't, probably in the future won't have to do what Dr. Shlomovitz did, which is complete a full radiology fellowship, and then a full surgical fellowship, and then a interventional endoscopy fellowship. That in the future, by leveraging the ability to do things like image fusion, simulation, and things like that, that we'll be able to train these hybrid practitioners in a reasonable length of time. Maybe a little bit longer than normal. But when somebody takes ultrasound, which admittedly takes a long time to learn, and fuses it to a 3D CT image or an MRR image, you can learn quite rapidly. Because we're used to looking at those other images, we're not used to looking at ultrasound images. And we think, and we have some early data that says that the learning curve for things like that is markedly decreased. So we think in the near future it's going to be quite possible for a surgeon or a gastroenterologist to learn how to apply these image-based things that right now take years and years of practice looking at images and use them in a very practical and applicable way. Operating rooms of the future, really this is our building. We think operating rooms are going to look quite a bit different. This is kind of our thing. It's, it's got robots, it's got imaging machines like CT scans, MRIs, it's got laparoscopic stacks, it's got endoscopic stacks. They all talk to each other. They're all interconnected and talking, and with artificial intelligence, they translate the data that's being collected into a usable fashion for the practitioner. So we think it's going to be a mass collection of data, but also a mass translation of that data into a practical format for the practitioners. This is kind of how we see patient flow happening in our operating rooms, where patients, instead of having a preoperative image, or even if they had a preoperative image, will get a image at the beginning of a case. That image will be registered, and it may be multiple types of imaging, each one augmenting, providing some useful information, like maybe imaging specifically for nerves versus imaging for vascularity, and then intraoperative registration of that image into and combining it with video images or the endoscopic image, so it's kind of in a usable format. So it's applied radiology, if you will. At our institute, all these things are very hardwired into the education paradigm because we really believe in education. This is admittedly a new concept. And so everything's connected, everything communicates with our education facilities, and we record every single procedure that's done in the hospital. So we collect high-definition video on all of these and use that for education purposes. So how do we train this new practitioner? I think Eran is really my hero on this. He's one of the first at the University of Toronto to do that kind of dual pathway that was approved, interventional radiology and surgery, and then he came and spent a year with me. I was very fortunate to have him to learn advanced flexible endoscopy, and that's what his practice is. It's a combination of laparoscopic surgery, flexible endoscopy, and he just does whatever works best for the patient. Of course, it took him 9 years, something like that. So we have Professor Jimenez from Buenos Aires here. He published this very fine paper about this kind of future. He's one of the visionaries of this whole future of percutaneous surgery, and he's working actively with us in Strasbourg. We're very fortunate to kind of make this a reality. He trains now in Buenos Aires. He's a group of general surgeons that do all their interventional radiology in Buenos Aires. And he's helping us kind of create this new pathway. We put on courses, so this is very active. We're very serious about this. So multiple courses extending from 2 or 3 day courses, hands-on, et cetera, all the way up to university degrees in hybrid surgery. So this is kind of ongoing in one of our missions, and as you can see from the dates, is happening even as we speak. So in conclusion, Mr. Co-Chairman, laparoscopic surgery and even flexible endoscopic surgery isn't the end of the MIS journey. There's things beyond it. There's things less invasive, and after interventional radiology, it's going to be molecular manipulation and immunotherapy and cellular surgery. Image-guided percutaneous surgery offers even less invasive and more cost and patient beneficial alternatives for a growing list of diseases, and that list is going to keep growing. Modern technology can and is making mastery of this new practice accessible to surgeons, and it's changing what surgeon means. And when I say surgeon, I'm not talking about whether they were trained in a general surgery resident. I'm talking about people that operate on patients. And this might be an interventional radiologist, and maybe he's now using a 3mm laparoscope to kind of see things a little bit better. It might be a flexible endoscopist relying on EUS and doing 3D imaging and image fusion. So surgery and surgeon is going to expand. So I encourage all of you to keep an open mind, think about this carefully, and think about implementing it in your practice. Thank you.
Thank you.